Hello and good afternoon, wherever you are in the world. Thank you very much for joining us. I think I'm hearing a little bit of feedback, so I'm going to just switch on my headphones just in case. We've got with us a very interesting panel of experts from across the world. So we've got Dr. Shankara Shetty in South Africa. We've got Kanan Janakaram from India and Dr. Murali Krishna in India as well. So welcome to everyone here, and thank you very much everyone for joining us. Now listen, as I'd said before, our aim here is to try and make sure that we focus on science, and we are trying to find solutions, real solutions that are there for people who maybe are struggling with regards to getting access to resources. Any problem in the world is a problem for the rest of the world. And this is why we believe that there may be some value to hearing our thoughts from this group of experts and sharing ideas as to the way forward. So let's just start. Murali, do you mind just doing a quick introduction of yourself and where you are?
Yeah, hi. I'm a practicing family physician in Bangalore, India. We are currently in the kind of the storm of COVID, and family physicians, healthcare infrastructure is highly stressed, and yet facing this onslaught strongly.
Wonderful. And Kanan, yourself?
Hi, I'm a pharmacist and biomedical scientist. I'm based out of Bangalore, and I've been following this whole story in India closely with regard to the resource constraints what the hospitals are facing.
Wonderful, thank you. And Shankara?
I'm a family, hi everyone. I'm a family practitioner from South Africa, and I'm currently seeing coronavirus. I've been doing this for over a year now.
Wonderful, wonderful. Thank you very, very much. Listen, I'm going to start off probably focused on a few of the basics about what's happening in India and in terms of their general system. And so, Kanan, do you mind just giving us an idea as to how the health system tends to operate in India, the private versus the public health?
Sure. Now, I have to immediately compare the Indian situation with the rest of the world, at least the developed countries. Unlike the West, we have the private hospitals in India, the private healthcare system dominates in relation to the public healthcare. The access to technologies and developments in the healthcare is limited most of the time to the private healthcare system, whereas a public healthcare system is confined to primary healthcare in the rural India. Now, in a situation like COVID, the pandemic situation, the cities are strained because there is a huge number of migrant population walking into the metros in India. But in the rural, the access to essential medications is an issue. So there are two different problems here. One is the population concentrated in the cities versus the lack of essential medication access in the rural.
Right. I understand. And so, Murali, in terms of the last few weeks, what's going on the ground in Bangalore, as opposed to, say, I think that we seem to perceive that it's not the whole of India that's hit hard. It's primarily some of the bigger cities like Delhi, Mumbai. Is that about right?
That's what the numbers are telling us, that it's the larger cities, but we'll have to assume that even the smaller towns and tier 2 cities are affected. It's just that probably the testing is better in the larger cities. So I think we'll have to keep that in mind. Well, in the last, since the end of March, the numbers have been steadily rising. And now the numbers are really overwhelmingly high. Like just yesterday, in spite of a lockdown for the past week in Bangalore, we have 24,000 active cases in the city of Bangalore itself. So, and you can imagine if there are 24,000 active cases, there would be at least a small percentage of them, even if you take 5% of them, who would need hospitalization and intensive care, right? So that itself is quite overwhelming for the healthcare infrastructure. Of course, and all this burden tends to fall more on the private healthcare system. The public healthcare system, as Kannan was just saying, is limited to more primary care, and there are very little tertiary care facilities for inpatient care. So the government, I mean, the hospitals are trying to do all they can in terms of building quick COVID care facilities, and private hospitals are helping, and a lot of medical colleges are opening up their infrastructure, and a lot of COVID care facilities are opening up and just adding as many beds as they can. But still, to be really honest, the situation is quite overwhelming.
Yes.
And I think that's the current situation. With
Wow,
24,000 cases, you can only imagine in one city.
Wow. Yes, yes. And so, and Shankara, I'm bringing you here now because I need you to explain why your experience in South Africa is probably so important and relevant to what's happening in India.
Philip, the method with which I managed my patients was all on an outpatient basis with medication and no oxygen. Or I've managed to negate the need for oxygen by catching patients early and treating them early. I think what we need to figure in India, we've been talking about the 2 stages of this illness and the 8th day where things change. Now, with the variants that we're seeing around the world, the differences seem to be in the initial presentation in the first 8 days. The different variants tend to present with different severities and also different systems that are affected. In South Africa, we saw a lot more gastroenteritis in that first viral phase during the second wave with the new variant. So I think we got to be very quick in India to find the presenting symptoms for this unique variant that they have. I'm suspicious that the variant in India might have very mild symptoms that might go unnoticed. And so people won't get tested too frequently. That would cause a lot of patients to present in the second phase with the breathlessness and all that kind of thing. And so we might be masking the viral illness and having patients present critically ill. So our treatment as well needs to be adjusted accordingly. I see from the news reports as well that we're having a lot of panic in India. I had that during the second wave here in South Africa. When you have such a contagious strain, it spreads very quickly and you have a sudden rush of cases to the hospital. And I think because of the deaths, there's a lot of panic. I saw a lot of patients who thought they were breathless, but were actually starting to have panic attacks. And I see a lot of that happening in India as well. Mm-hmm. So I think we need information about the onset so that we can predict the 8th day. And we need a shift in the way we look at it to see what kind of patient is actually presenting to the hospital. Is this a patient with viral illness? Or is this a patient presenting with a severe immune reaction? Yeah. And the way we respond to that will be very different.
Yeah. And so, Kannan, from your point of view, because you've been seeing some of these patients on the ground as well, from another angle, what are your thoughts on what Shankara was just saying?
Significant amount of GI symptoms, manifestations we see in the second phase. So that is one. Sometimes these patients don't have the upper respiratory symptoms, but they have GI symptoms. So there goes the situation where patients themselves will take it as gastroenteritis, which is common during the summertime in India. So they are presenting with diarrhea. So, and as Shankara rightly pointed out, when this happens, you tend to ignore that it is a viral infection. Sometimes doctors also might think it is rotaviral diarrhea. It's very common. So we have to take shortlist the common symptoms in the second phase of the infection and take it for granted that they should be targeted as the viral infection, and then go ahead with the next step of actions for the clinical management.
Wow, interesting. And Murali, in terms of your experience, is that a similar pattern that you're seeing?
So when a patient walks in, we are asking them for both the upper respiratory and GI symptoms, right? And to be clear, and for, of course, even musculoskeletal. And we are seeing varies, right? I'm seeing upper respiratory only, and I'm seeing a mixture of upper respiratory and GI symptoms. So that's what I'm really seeing. And yeah, and to agree with Dr. Chetty's statement that, people actually are neglecting visiting the clinic or consulting a doctor in the first week, where they're losing out on the opportunity of medical advice earlier on. And many times they neglect and they tend to reach us itself on the 8th day, 9th day, right? And then we have to identify them that they're the second week and they're already in the inflammatory phase of it. And of course, that's when we quickly need to start them on the steroids. Right? So that's happening a lot. We are seeing people, actually many people are reaching out to me on the 8th day, 9th day.
Right. So this is where I think the what I learned from speaking with Shankara recently is that there is a huge opportunity for very early aggressive intervention, and by watching the characteristics of the disease. It's very important to know is that I think we've all accepted in the scientific community that the immune dysregulation is a critical part of the deterioration. And therefore, it seems as though the most effective drugs that we have found so far are immunosuppressive, specifically steroids. And so, Shankara, I want you to explain to us your principle of the 8th day. I think that's a really important principle for us to get in order to help people to understand how to approach the disease, even as non-clinicians, how to know when to look out for symptoms.
All right, Philip. With all the patients that I've seen, I noticed a distinct switch in the symptoms of the illness on the 8th day. And that had no bearing on what transpired in the first 7 days of illness. So I had patients that were severely ill in the first 7 days, recovered by the 6th or 7th day and had no further symptoms. And I had patients where they had a sore throat for a day, recovered from that, but on the 8th day presented with new symptoms. And whichever patient presented with dyspnea and that kind of thing, it was always initiated on the 8th day. So the 8th day became a very important point in the evolution of this illness to change our strategy with treating. On the 8th day, I stopped focusing on the virus itself and started focusing on the immunity. And that was the most important thing in saving lives and negating the need for oxygen. I had a lot of patients come in with very low saturations on the 8th day, but they were not breathless, the so-called happy hypoxics. And I didn't feel the need to immediately put them on oxygen. I think when we look at saturation levels, we got to be cautious about reacting too quickly. I think a dyspneic patient would require oxygen. But even a patient with low saturations that's not dyspneic, we don't have to rush to oxygen too quickly. And all these patients, when put onto steroids and a strong dose of antihistamine, their saturation started to improve very quickly. Within a few hours that they started to notice improvement in their symptoms. So I think it's critical for us to try and catch patients as early as we can. The initial treatment, the aim of treating patients from the first day was to get them prepared for the 8th day. The viral phase tends to be self-limiting. Generally, patients recover from that. By the 5th or 6th day, you notice that they're recovering. but we're not sure what's going to transpire on that 8th day and who might have this reaction. So it became important to prepare for that. I think in India, we'll face a bit of a unique situation as well, because we're getting people present on or after that 8th day. And so the virus shouldn't factor in our treatment regimen at all. We should be looking completely at immunity to try and stop those reactions. That would keep patients out of hospital. That would negate the need for oxygen. It would buy time with those critically ill patients. What we need to do is sift out the critical ill patients into those who can be managed at home and those who actually need hospital care. And I think early steroids, antihistamines, will actually solve that problem. A number of patients can recuperate at home on a high dose of steroid with an antihistamine, and they recover. There are a small percentage who take a while, and those are the ones that might require hospitalization.
That's
so
interesting.
We need to do that.
Interesting point. And I was just talking with Murali in terms of the therapy recommendations in terms of India for treatment. And in the mild symptoms, do they include an antihistamine at all?
Yes. We would give them levocitrazine sometimes when they're in the mild phase of it. And just to add to Dr. Chetty's point of the low saturations, yes, what we're actually doing is we're not just checking the saturations or the respiratory rate, of course, but we're asking them to do what we are doing here is a 6-minute walk test, right? So once the patient comes, we check the saturation, or when they call us from home, we ask them to check their saturation, and then we ask them to walk for 6 minutes and then recheck it, right? And then if the saturation drops after walking for 6 minutes for more than 5 points, right, then we are considering that as a significant impact. If it does not drop, then we are telling them not to worry, stay back at home, and then depending on the day they are in, whether they are in the viral phase or in the inflammatory phase, we're recommending treatment.
That's a really good practical idea that you guys have implemented.
And to your point about the dose that you just said, right? So if in such a case where the saturations are maintaining after the 6-minute walk test, and if they're in the second week, then yes, starting, and if they're having symptoms in the second week, right? Also, then we are starting on 2 things. One is prophylactic anticoagulants, as well as steroids. And the steroid doses that I'm currently using are around up to 16 milligrams per day, and goes up to around 9 to 10 days on a decreasing trend. So that's what I'm using, and that has been working so far.
Yeah, it's an interesting point, Shankar, and from a pharmaceutical point of view, you can think about this Canan as well, is that one of the issues is that I point out to people is that in terms of treating patients who are having immune problems, the dose of steroids is actually critical. So Shankar, from your point of view, you are using about 80 milligrams of prednisone. What made you choose such a high dose? Because the other doses are much smaller. They're the equivalent of a quarter, sometimes a half of the dose that you found worked.
Yes, Philip. In the first wave, the standard dose, well, considered high dose prednisone is 50 milligrams. And I started using that as a middle of the line treatment. Dosage. And I found that worked very well in the first wave. It settled symptoms relatively quickly, and with tapering off, patients didn't have any re-emergence of their symptoms. But when I got to the second wave, the dosage of steroids is a little bit of trial and error initially. You're looking for quick clinical improvement. And early on in the second wave, I had a few very difficult patients where it took a while for them to recover. And very quickly, it became evident that I needed to up the dose of steroids. And once I did that, I started to get clinical recoveries. Now, 80 milligrams was, I would say, the average dose I needed to suppress symptoms. Whenever I went below 80, I started to experience difficulty in suppressing those symptoms. There were a few patients that I needed to go much higher. There were a few patients that I had on 100 milligrams TDS for 2 or 3 days just to get them over that initial severe reaction. And then you can steadily decrease it. So I think the steroid dose should be higher rather than lower, because those patients that get a lower dose, if you do not stop it timeously, you'll find you have a lot of difficulty trying to get them off the steroid, because you haven't really suppressed the reaction completely, and you're getting a cascade of events from that. So I always thought that you'd rather start high, have the patient improve in a very short space of time, and then cautiously withdraw that steroid.
Any thoughts about that, Canon? From there are some risks. Go ahead. Sorry.
I think as a pharmaceutical guy, I generally the dosage of any drugs are decided based on the surface area. Vis-a-vis Indians to the rest of the world, I mean, I would say I would get that feedback from Shankara that the body surface area is pretty large in those populations. So if you look at the dosage according to body surface area, probably what Murli is doing is sufficient enough. But if the side effects are limited with upping up the dosage, I think you can still consider going for higher doses. And there was a point he mentioned in your discussion that he was worried about the diabetic patients, which like the way the blood sugar control and high risk of steroids. And there you have to look at the risk benefit. So if it is to treat the COVID, I think you can still manage the blood sugar levels with
I think regime. Yeah, a good point, Canon, in terms of, I guess one of the points is that when you're looking at short-term use of steroids, even at relatively high doses, the complications are there, but they're much less significant than when you're using high-dose steroids for a prolonged period of time. And Shankar, I think you had found that just 5 days at the higher dose was about adequate.
Yes, Philip, it was. There were those patients who took longer to recover. And I think that subset, a very small percentage of patients, needs to be investigated a little further. Whenever I tried to withdraw the steroid, the reaction would seem to want to flare up. I am of the opinion that is likely to be because of a persistence of the allergen in the lung. Those patients tended to be those that developed a very dry, irritative cough in the first 7 days. And they tended to take a long time to get off the steroids. But coming back to the diabetes, I think that we must be cautious not to withhold the steroid for fear of any side effect. The withholding of the steroid will have far greater implications in the long run. Just an example, I had a diabetic hypertensive patient of 75 years old who presented with COVID, went into the 8th day, had a very severe reaction. I had to put on to very high dose of steroids. I think I had on 80 milligrams BD to start with. Her condition worsened and it looked like she had developed pulmonary eosinophilia. So I used ivermectin at that point and she improved. I kept her on the steroid for 2 or 3 more days and I was in the process of, she had improved drastically and she was, I would say, back to reasonably normal in those 3 days. And I was slowly tapering off the steroid. And on a fateful Friday, her family admitted her to hospital with a sugar value of 26. The range is below 7. And so they were concerned about her sugar being so high, so they admitted her in hospital. The physician in hospital promptly stopped the steroid, stopped all the medication, and started to treat her raised sugar. So he added a few oral anti-diabetic agents. She was discharged on Tuesday the following week. On Thursday, I got a call from the family to say she had taken a turn for the worse. And so I promptly asked them to bring her back in. Her sugar was 2.5. She had a hypoglycemic event. I immediately stopped all the oral medication. And I was concerned that the steroid was stopped very suddenly, especially with someone who had such a severe reaction. And with the steroid, I had monitored her CRPs and interleukins, and they were back to baseline. So on that very day, I repeated a CRP and interleukin because she had been off the steroid now for almost a week, and it showed a slight upward trend. I repeated it 4 days later, and it had doubled. And I repeated it another 3 days later, and it had doubled again. So I was of the opinion that we had not suppressed the reaction sufficiently, and it was slowly starting up again. So I had to put her back onto the dose of steroids to get those values down, but advise her on how to monitor and manage her raised sugar with her insulin. And she recovered completely.
That raises an interesting point that you were mentioning before, Murali, with regards to you guys are monitoring some of these inflammatory markers to determine, even in the outpatient section, who to target with regards to therapy.
Even in the outpatient, yes, more than outpatient, we are trying to manage people while they're at their home, right? And we're telling them over the telephone, we are giving them teleprescriptions. And we are asking them to monitor their vitals, blood pressure, SpO2, and share it with us. And there are lab services that do home collection service and give them the reports. So now with, if I may mention a case where it's a diabetic patient who comes to me on the 9th day, right? And the diabetes is on the range of like 400 postprandial sugar. Here we say in milligram per deciliter, it's 100 to 140 is normal. So the postprandial is 400, right? And I like you said, like Dr. Chetty said, he was on oral hypoglycemic drugs. I stopped him on the oral hypoglycemic drugs. I put him on insulin. And we had immediately trained him, sent him videos, and the patient immediately learned how to use insulin, right? And he started to use insulin. And along with that, we started the steroids, right? And we started the steroids as according to our plan. In fact, I started not even 16 mg, I started 4 mg TID, right? And I started him on also low molecular weight heparin, right? Now, so from 9th day to the 15th day, right? So we maintained his clinical status as normal, that we were not giving any IV fluids, just oral rehydration solutions minus sugar, just homemade preparations of oral rehydration, something like salt water with lemon, and making sure he was drinking 2 to 3 liters per day, and he was maintaining his hydration. But on the 15th day, when I did just a simple CBP, the complete blood picture, we saw the neutrophil lymphocyte rate was at 10. And absolute eosinophil count was 0. Both were poor prognostic factors and indicative of admission, right? But since the patient was stable, tried to pacify them, though I explained the situation to them. And after 3 days, we saw that the neutrophil lymphocyte reaction came down to 5, and the eosinophil went up to 90, right? So, and that was quite encouraging to see that you're managing the diabetes, brought down the sugar to around 250, and with low level of steroids, maintaining patient stability, and allowing the patient to pass through the cytokine storm, right? No. Without the patient even feeling it. The patient is actually asymptomatic in all this while, right? Because he's not in the viremia phase. He doesn't have any symptoms. He's just sitting in his home. He doesn't even know what is happening. It's just because of the lab results we are seeing that, he's gone through this crazy phase.
So this raises an important point, Murali, because that kind of level of therapy is exceptional, but I guarantee you that's not for the person on the street, if that makes any sense. When you think about the difference, so when we think about in the context of India, because these are the people that I'm really, really concerned about. So the people who don't have the income to access that level of sophisticated input, where they only have one shot to see the doctor because this is what they can afford. Those are the people who are at the highest risk of then deteriorating and not having access to the tertiary level facilities. And so from an objective point of view, Kanan, what percentage, when you think about the population out there, is that a minority? Is that 50-50, or is that a majority who will not be able to get that level of care?
80%. It's a majority. Okay, so let's not be very pragmatic in trying to say that we are all okay. So the solution here, is going to be stocking up the essential basic medications which still do the job, like what Dr. Shankar has done in his practice. I mean, that's a magical box of essential medicines, where you can prevent the patients from going into severe phase of the infection, and also hospitalization, or even esoteric tests, diagnostic tests. Okay, CBC is fair enough, but still, we need to look at the clinical manifestations and treat them accordingly, like what Dr. Shankar briefed in his session before. So the very clear solution is you have the list of essential medications stocked in primary healthcare system. And physicians also need to be empowered with that, information of experience, what the rest of the world has seen with using essential medications and managing it, resource constraint, setup. So solution is there, but we need to have the communication between the primary healthcare physicians should be uniform, and obviously forums like this has to be attended by most of them. But at least we could make a write-up and share it across to the primary care physicians. That would be the first thing which I would do. Just forward the copy of the paper of what Dr. Shankar has presented. That's going to be an eye-opener for them.
So
to add on to the essential list of medication, I think we forgot one more entity, which is a mast cell stabilizer. Okay. So unfortunately in India, sodium chromoglycate is off the market, off the shelves, but we have at least ketotifen.
Which one did you just say?
Ketotifen.
Okay, right. And you're quite right, because from what Shankar was saying in terms of the presentation, when the fact that they respond to antihistamine suggests that this is mast cell activation at the 8th day or in the 2nd week when they start to get unwell. And almost, because based on what you guys have been saying in terms of the tiers of care that exist in India, where you're going to find your mortality will go off the roof is the people who don't have access easily to a doctor and don't have access to private healthcare facilities. And they almost need, as you said, Kanan, an off-the-shelf pack that if they start to get unwell, they can just literally walk into a pharmacy and get it. Is that at all practical?
Yeah, definitely. It should be a situation of supervised self-management. Now, the supervision comes from the primary healthcare, along with pharmaceutical care from the pharmacist. So it has to be a collaborative effort, but at the basic level, which is the rural care, where it's knowledge empowerment what we require more than resource empowerment. Mm-hmm. Unfortunately, I have to make the statement because it is absent, and we have to very quickly empower this into the system, not only for this situation, for future pandemics as well.
And so, Murali, from what Kanan was saying, can you see any issues with that? So I'm not talking about your top level patients now. I'm talking about the guy who is on the corner, maybe selling some street food. He doesn't have access. Is it feasible for there to be that level of support? Is that actually even feasible?
Actually, if you see the profile of cases that have been observed by physicians and in discussion groups, it is not the people in the low socioeconomic status that are more affected. It is actually, it is people who are actually well-to-do, younger generation, well-to-do, who are able to socialize, go out, and like go to restaurants, pubs, are able to mix with a lot of people. These is the kind of people who are actually getting more infected. It is not, in fact, till now, we have not seen many very poor people who are affected. Though I see a lot of poor patients, not many are affected from COVID. The COVID patients are actually the kind of the middle class and the younger generation. That's what you're noticing. But I think it will definitely seep into the lower socioeconomic status as well, and that's happening. That's happening now. Yeah, slowly.
And so, yeah, so it raises an important point about the age group. And Canon, in terms of the age group of people who are affected in this wave, is it that the numbers are just so significant, or is it that the virus is targeting a younger age group?
There are a few points which I would like to bring to the knowledge of the listeners and the panel. Now, in the first phase, the extent of testing was not this intense, at least in the urban setting. Okay? Now, in the second phase, the testing is quite expensive, so therefore the numbers are expensive. Now, answering your age factor, the younger age are asymptomatic. So they are super carriers. And the middle age and the elderly are the ones who are having the manifestation. So,
no.
If you are, sorry.
No, I was going to ask a question there, because I remember Murali was saying that, interestingly, you are noticing a lot of younger patients with almost no comorbidities getting more severe disease.
Yes. Younger patients with not necessarily having comorbidities, because the older patients, at least in the cities, are vaccinated. They came under the vaccination program, and so at least their symptoms are mild and they're able to go through it relatively better. In those older patients who are not vaccinated, we are seeing a severe cytokine storm. Right? But in the younger patients, since they were not part of the vaccination drive, irrespective of comorbidities, once they are infected, then they would need to be monitored for the definite second week symptoms. Right? Some of them recover by the third, fourth day. That's great. Right? But otherwise, for those in the second week, they need to be looked for, for the inflammatory or any kind of symptoms. Any symptoms in the second week, then they need to be targeted with the prophylactic steroids and antithrombotics.
And Shankara, in South Africa, when you guys had your second wave, were you seeing younger people as well, or was it still, because your cohort wasn't really vaccinated?
Yes, Philip, we did see a lot of younger patients, but I see around the world that we're looking at the variants and considering them to be targeting a younger population. In the first wave, I did in my article mention that I expect to see a younger population affected in the second wave. And I think we're going to see this pattern around the globe. All the countries that go into their second wave are going to see younger people affected. The reason being, I was of the opinion that in the first wave, younger people were naive to the allergenicity of coronavirus. So we saw people 55 and older having a hypersensitivity reaction. So they were likely to have some sort of antibodies to this allergen from some prior exposure in their lives. The younger group was exposed for the first time. So in the first wave, the young population, even though asymptomatically infected, would have developed sensitization. And so in the second wave, when they develop a second infection, they are already sensitized. And so they will have a hypersensitivity reaction on the 8th day. And I think that's the reason we're finding that the patients that are presenting, besides being a lot younger, don't have the same comorbidity profile that we'd expect. You're getting fit young people presenting severely breathless. Now, we've got to be cautious with the second wave in all countries, that we don't start blaming the variants for this. I've gone as far, Philip, as to, in the first wave, the older members of the family that got the hypersensitivity reaction after the 8th day, I made note of that and actually warned the younger members in the family that they might be prone to having a similar reaction in the second wave. That they might have been asymptomatic in the first wave. They all say, tested for coronavirus. My dad got very ill, but I warn his son that in the next wave, he might go down that same road. And it's happened quite a few times. So it's just a means of me trying to educate the family as to their risks, finding a way to plot who might be at risk.
Interesting concept. Now, one of the other issues that you've made mention to, Murali, was the point about the vaccination. And it seems as though the older people who have been vaccinated, who we would normally consider high risk, are not getting severe disease. And that seems to be playing out in India as well. Is that about right?
Yes, that's the case. But we should take that with caution. We can't neglect it. Just because somebody is vaccinated, we should still follow them for the second week. And there are those cases, few cases where, though there are no symptoms of any inflammatory sense in the second week, but in a few of them, when I monitor, I see a raised D dimer, right? So I start them on prophylactic anticoagulants. So they are not even, though they may not even require a steroid, right? So it's sometimes important to monitor for the thrombotic disease as well. It's important to keep that in mind.
Yeah, and
so that's the point. They're symptom-wise, they're all right. They're not suffering so much, but we still have to monitor for the thrombotic part. Is my lesson.
Yes.
What I've learned.
It raises another important point, especially when there is a vaccine limitation. But Kanan, you were saying that the reinfection rate is very, very low for people who have had a previous COVID infection. Is it sensible to vaccinate them?
For sure. Well, now one of the reasons behind the low rate of infection, what you see is the adaptive immunity develops within 2 weeks, right? And it stays for 6 to 7 months. That's the claim from the clinical trials. Now, the breakthrough infection happens in cases who are vaccinated, but within 2 weeks they just go out and think that they're otherwise okay. So there has to be a caution taken by all those vaccinated also not to get exposed, deliberately, at least for a couple of weeks before their adaptive immunity develops. So that is something which needs to be kept in the minds of people who are already vaccinated.
Mm-hmm.
So if you're vaccinated, you're safe for another 2 to 3 weeks until your adaptive immunity develops. So you still take precautions after that.
I'm going to put Shankara a question here that I think I've asked you before, is that based on your clinical approach, and at the moment, yes, there is a big push because we can see people who are vaccinated seem to have milder disease. Do you think it is possible that people can be managed even without the need for vaccination on a very large scale if they are appropriately treated?
Yes, Philip. Just to narrate an example, when I started treating COVID, it was limited to my regular clientele. And when I figured that we had dealing with the biphasic illness, I published an article on it. That was spread around South Africa, and a lot of the public got word of that. And so I started getting people driving from far and wide to come to my practice. It eventually became a problem that I had a mob at my gate every day of very breathless patients that had driven a long distance out of fear and had gotten to my practice. Now, I found I had to manage 70 or 80 patients a day all on my own. Now, the reason for me setting up a tent and wanting to treat patients was to understand the the pathophysiology of this illness. It was an academic undertaking. I wasn't expecting to see every patient and examine every patient myself. That would pose a great risk, and especially patients that I was unaware of. I had no history from them. I didn't know their chronic conditions. They just pitched up at my door and they asked for attention. So what I did was I decided to triage them. All those that came with corona symptoms or positive tests that were not my patients, I decided to limit my interaction with them, to limit my risk. So I had chairs out in my parking lot. I put a little gazebo out there in full view of everyone. And I would have a patient come and sit in front of me just for a minute or two. My aim was to find out where they are in the illness. Am I dealing with someone in the first 7 days? Are they presenting early? Or is this past that point? And right there, I would prescribe the medication to take home or the script that they would require. So it took a minute to two with every patient. And I managed to get through large crowds of people in a very short space of time. So we don't need to spend a lot of time examining patients and doing all the blood tests and all that kind of thing. I think we can diagnose this illness and treat it very symptomatically. All we got to do is recognize that 8th day. Are we before that 8th day, or are we dealing with someone after? I've had patients come on the 15th day with saturations of 50%, really struggling to breathe, very fatigued, had to be brought in on a wheelchair. The approach is the same. I put them on a high-dose steroid. I used antihistamines for the gut and for the upper respiratory tract. I added montelukast and a high dose of aspirin to prevent any clots. And all of them within 2 or 3 days had good improvement. And none of them were monitored after that. So a lot of them, I would give them a week's treatment. I would ask them to contact me if there wasn't improvement. And the majority of them improved without having the need to contact me.
And so, in fact, then, based on that, I mean, when we think of what Murali is doing already, he's giving them steroids, he's giving them low molecular weight heparin, and they're getting antihistamines. Is there any need to adjust that? Because it still seems as though what's happening in India, even with that regime, people are still dying, not necessarily Murali's patients, but I'm assuming that across the board, patients are getting that and still getting on well. Should it just be a block of 5 days with high dose prednisolone, aspirin, and so on? Is that just, you see, because part of the problem is that you may not be able to do what you did, which is to examine every patient. If
Yes.
you are then delivering it, as Canon says, at a pharmaceutical level, where it's almost a kit that patients take home with them and wait for their symptoms. If they deteriorate, they have it at home, they take it immediately. How can you standardize that?
I think what we need to do, Philip, like I did in the second wave, I worked on a minimum effective dose of steroid. So 80 milligrams per day was the minimum I required for a patient. And so that became the norm. So I wrote out a script with 80 milligrams prednisone a day, promethazine 25 milligrams twice or 3 times a day, depending on the patient, for 4 or 5 days, Ecotrin or aspirin every day. And I gave that to every patient. I even, on the script, I plotted the patient's 8th day and gave them a script warning them that if there was a deterioration on that 8th day, start these medications. Now, what I found was that, look, if you look at the 8th day, you have patients who have very mild symptoms, but if you leave those untreated, there is that risk that they will slowly, progressively get worse and eventually end up in a cytokine storm. Now, I had that happen, a simple example, I had that happen with 3 of my family members. I have an aunt that's 85, her husband's 87, and her son-in-law, who's 58 with a few comorbidities. All 3 of them had COVID. The son-in-law's 8th day was on a Tuesday. The father-in-law was on the Wednesday and the mom-in-law on the Thursday. And I warned them about all the relevant symptoms and to note to me. On Saturday, they had not contacted me, so I got in touch with them to find out how you're doing. And all three reported fatigue. The daughters are pharmacists. And when I spoke to them, they said, no, mom and dad are doing fine. Dad and my husband's just got a slight cough, but all three are complaining that they're feeling a little tired. Now, that's a sign to be very cautious. They had fatigue on the 8th day. So this is Saturday already. So I promptly asked them to all go for CRP and interleukin-6 levels on the Sunday. The brother-in-law, who was longest past the 8th day, had a CRP in the 400s. The father-in-law, who from Wednesday, this is Sunday, had a CRP in the 300s, and the mom was 100 and some odd. All three had raised interleukin levels, but all three were just feeling a little tired. This was a time bomb waiting to go off. So immediately on the Sunday, I started them on high-dose steroids. On the Tuesday, I repeated their bloods, and all three of them showed a turnaround, coming back down. But I did their D-dimers, and that showed a slow increase. So I had to put them on anticoagulants and manage them. They did develop some breathlessness. I had to use ivermectin. But all the complications came from deferring treatment on the 8th day, respectively. You could see that slow, steady deterioration. And this is what we see with patients. They feel a little fatigued for a few days and suddenly collapse. And it's a crisis. So we need to be early. And Philip, if I look at the administration of steroids, I always have to consider my intervention against the risks and the benefit. Now, if I give a patient that's absolutely well, 80 milligrams of prednisone and a Phenergan twice a day, I think the worst that will happen is he'll be a bit drowsy for a few days. And after that, recover completely. So the risk of taking these medications the benefit of taking these medications far outweighs any risk of it being taken inappropriately. So that's when I decided I'm handing you a script for the 8th day. You're going to decide on that day whether you're feeling well or you notice the deterioration, and you would preemptively take that medication. And I had a lot of patients present on the 8th day with severe dyspnea, body pains, that kind of thing. And they decided they're starting the script. And I never had to see them. They reported back after a week to narrate all that transpired. But the preemptive script sorted it out. They never needed oxygen. They never needed tertiary care in any way. So I think we need to preempt this. Educate patients about what might transpire a week after the start of their symptoms. And if there's a deterioration in any way, exactly a week after the symptoms started, we need to come to a minimum effective dose of steroid and have that given out to every patient. I explained to patients that when you start the steroid, you want to see improvement within a day. So the only patients that presented to me were those that started the steroid but didn't have significant improvement. So it sifted through the crowd to those I needed to manage better.
Wow, excellent. And so, Kanan, is that from a pharmaceutical point of view, is that at all practical?
We have to make it practical with the strategy of engaging multidisciplinary professionals within the healthcare ecosystem. So a physician alone cannot do this. It has to be physician assistants, pharmacists. Everybody should be empowered to play a role in patient management.
Yes.
Primary healthcare.
Yeah.
So nobody should be left out in the healthcare ecosystem. We all have a huge role to play. As a country in India, there's no dearth for life scientists, healthcare professionals, paramedics. So the onus has to not lie within the physician's own. Family will be overwhelmed. The hospitals will be overwhelmed. So there has to be an education process which Dr. Shankar has initiated himself.
I'm struggling to hear you, Kanan. I don't know. Do you have your head?
Education.
Yeah.
Yeah.
So I think we got kind of interrupted there. But Murali, if you imagine,
Can you hear me?
Murali, oh yes, I'm hearing you better now. For some reason, it was very, very faint when you were speaking. And so,
Okay.
but I understand your point that it requires a more holistic approach in terms of it's not just
Absolutely.
the doctor who is prescribing something. And so, Murali, from as I said, from a practical point of view, would you? I mean, you seem to be happy to give the patients the outpatient scripts and so on, but would you have any concerns if there was a standard script available for any patient to just go to the pharmacy and get, not necessarily even needing to see the doctor?
I think if we are, according to what Dr. Chetty is saying, right? If we understand this disease better, right, then there would be no harm. But at least in the second week, a physician-guided standard prescription would help. We just don't want somebody to go into a severe thrombotic disease and get affected. If you think the minimum effective dose of steroid is a good strategy, then there should be no harm in implementing it. That sounds reasonable. And if it has worked with patients who have not been vaccinated at all, and if none of them have died, right, then why not? Right? You should only be open to trying it out. So,
yes.
I think that's a good idea. But I think at least one consult with a physician in the second week is, a physician-guided approach is something that I would like, right? Not just a blind, take medication, because people still need to be told how to take medications. Because if you just give them a pack of medications, it's not even a good idea to take steroids in the first week, right? And it requires some level of education and some level of communication with the patient. And that kind of skill is there. I doubt if it's there with the non-medically trained person, right? So you need to be able to tell them that you're in the first week or in the second week and when you need to start all this. And you need to be able to tell this patiently, right? So I think it's a good idea if somebody consults at least once, and then a standard dose of medication, something that works, a strategy that works is a good idea.
Yeah.
For, especially in a case like this where, things are getting out of hand.
Yeah. So as we start to, sorry, you're going to say something, Shankar, before we start to wrap up. Go ahead.
Yes, Philip. Just at the start of the pandemic, I deal with a wide diversity of socioeconomic groups. And you find that patients of the higher socioeconomic group tend to engage more in self-medication. And so initially, I was having a problem with the higher socioeconomics group presenting too late. They would try the pharmacy over-the-counter meds, they'd try the self-medication, and only after the 5th day, when they find that they weren't improving, present to me. And in that group, I was having an overlap of symptoms. So I spoke to the local pharmacist and said, look, it can be a dangerous thing to be giving patients medication for the flu. You might not be realizing that these are corona patients. And on the 8th day, when they take a turn for the worse, we're going to have a lot of difficulty. So the education of the pharmacy was important, and the pharmacist then started sending every patient with a sore throat to go and see your doctor. This higher socioeconomic group, there was difficulty in educating them because they tend to think that they know how to manage these kind of things because they've done it all along. But I found in the lower socioeconomic group, it was much easier to educate them and explain to them the gravity of what is there. I was pretty surprised that I had a rural illiterate population presenting to me with a sore throat on the 1st or 2nd day. And when I'd explain to them, they would say, yes, we're well aware that we should come early. Because they're not exposed to media, they're not exposed to all the controversies, and they tend to look to their healthcare professional for sound advice. And once the word got out that the 8th day was critical and you needed to be better by that 8th day, they started presenting early. And those were the patients where I could give them a preemptive script and say, look, you watch out for this day, and if you notice these symptoms, start this medication and present to me as soon as you found the need to start it, so that I could manage them. So I think the pharmacies have a place to play. You have to have a consult with your doctor to at least understand where to take this medication. But then when we're dealing with a crisis and hordes of people presenting to a hospital at the same time, it's easy for a healthcare professional with a bag of medication with steroids and antihistamines in it to just triage patients along that line, and you can hand them a bag of steroid and the antihistamine and the anticoagulant and say, go home. And if by tomorrow you're not feeling better, come back. And we take away all the burden on the oxygen and hospitalizations and that kind of thing.
Wonderful.
Because a lot of early hospitalizations are not necessary. Patients recover quickly, and we're spending 5 days monitoring them in hospital for no real reason.
Yeah, excellent point. So as we come to wrap up here, Murali, where do you think this is going in India, and what warning does it have for the rest of the world?
Well, in India, it's currently in a, I'm not sure we have reached the peak yet, right? So we are still, we need to still be prepared for the craze is still rising numbers. And it's not just the healthcare fraternity. I think the public need to take this very seriously, because it's very nice, to find somebody to blame, but the public, really needs to, especially the younger folk who find it very difficult to stay home, right? Need to really be aware that they need not come out and mingle and just wait for some time, wait for a couple of months, maintain isolation protocols, right? And I think that's the important lesson. And healthcare fraternities, anyways, trying their best across the country and across the world. Everybody is taking this very seriously and working very hard throughout, right? And so this is not just a problem for India. I think it's going to be a problem for the world, and the whole world should prepare very much for something like this, whether vaccinated or not. Just vaccination doesn't make somebody a superhero, but vaccination definitely helps. Again, that you should make that statement very responsibly, because there are those who do not want to get vaccinated. So definitely vaccination has a great role to play, but you still have to be cautious. That's the point, right? Vaccination definitely decreases the symptoms and the severity and the need for hospitalization. Just that you need to be cautious. And so the entire world still needs to be prepared for such kind of a wave. It's just that India is affected now. We don't know tomorrow how it's going to be in any other country, how the wave is going, because this disease does not have borders, right? So we just need to be cautious, and really at a time like this, really be prepared to really share information like this, educate each other, and help each other in any way we can.
Yes, excellent. Thank you. And Shankara, any thoughts?
Philip, with looking at it from a population perspective, I've had no patients get into crisis in the first 7 days. All the patients that presented severely ill did so in the second phase of the illness. So if we look at India and all the patients that are presenting breathless or critically ill to hospital, they are in the hypersensitivity phase of this illness, or the allergic phase of this illness. And so what we're dealing with, in layman's terms, is a country that likely was stung by a bee. And all the individuals that are allergic to this bee, be it mild or severe, are now presenting to hospital en masse. And so I think the way we address it from a treatment perspective is critical. If we look at it as an immune presentation, we will deal with it that way. But if we look at it as a viral presentation, we will waste time. And that is critical in keeping patients out of hospital.
Wonderful, wonderful. I'm sorry that we've lost Canon. I can only, I guess he must have had some internet problems, but I'm sure he would have had some unique thoughts to share with regards to what he thinks, where we're going in the world. And as we wrap up, I just wanted to say thank you again, gentlemen. We really appreciate this, the thinking, especially Murali and Canon, sharing on the ground some of the reality that's going on. Shankara, from sharing from your experience. And most importantly, it highlights that we all need to be prepared. This is not going away. We have not overcome this. The vaccines are mitigating it, but it doesn't seem as though it has completely stopped the disease. So it's a good opportunity for us to reflect on the way forward as we learn, hopefully, from what's happening in India. Gentlemen, just hang on there. Let me just do a quick video as the outro. And thank you, everyone, for watching until we have our next meet again.